Hello, podcast listeners. We know podcasts are a great way to catch up on a program that you may have missed on KSJE, and it's provided as a free service of this radio station. But you know, KSJE is now listener-supported, and so while you enjoy this podcast, we hope that you'll also take some time to join KSJE. Become a member today. It's quite easy to do. Just go to our website at ksje.com/support and pick the level of support that best matches your budget. Thanks again for listening. Here's your podcast. 20 minutes past 8 o'clock. It is Wednesday morning, the 11th day of March, 2026. Good morning, everyone. I'm Scott Michlin. Thank you for tuning in to KSJE 90.9 FM over the air right here in San Juan County, New Mexico. In Durango, Colorado, we broadcast at frequency 103.3 FM. And if you're listening to my voice from anywhere else on the planet, you've gone to our website to tune in, ksje.com, or maybe you're listening through the KSJE radio app. It's great to have you all with us this morning. Welcome aboard. Also, welcome to our viewers who are watching the program. The video is streaming out live to the KSJE Facebook page and also to our YouTube channel. So it's great to have you along, everybody. Coming up in the next few moments, my guest from San Juan Regional Medical Center. We're going to be talking about healthcare and AI, artificial intelligence, and as it relates to healthcare and how it can help doctors and nurses and other staff at the hospital. Stay tuned for that. Coming up, my guest from San Juan Regional Medical Center in the next few moments right here on KSJE. Then, of course, we invite you to stay tuned. Next hour, it's our classical music program, Roving with the Arts, beginning after the news at 9:06. Mick Hess will be here playing classical music for about 90 minutes to take us to 10:30. And right on Four Corners, our local and regional author program. This week, Delcherie Spinner is talking with author Sky Griffith about her latest book called Bone Hash. You'll hear that interview today at 10:30 right here on KSJE. Don't forget, you can also connect with us on other forms of social media like Instagram or Blue Sky or X. And if you're a podcast listener, we publish podcasts almost every day. You can check it out and maybe discover a new local program that you may have missed recently. Or better yet, find our podcast, live streams, and much, much more on the KSJE radio app. It's available at the App Store and on Google Play, so check that out. Outside our studios this morning at San Juan College, a cloudy Wednesday morning so far, 41 degrees. We're expecting some increase in sunshine today, but also some windy conditions too. The high 60 degrees this afternoon. Wind gusts up to 40 miles per hour are possible today as well. Clear skies overnight, the low 36. Tomorrow sunny and warmer with a high of 63 on Thursday. Sunshine 66 by Friday. 70 degrees are possible with sunny skies on Saturday, and overnight lows in the mid to lower 40s. I'll be back with my guest from San Juan Regional Medical Center right after this on KSJE. KSJE is supported by San Juan Regional Medical Center. It's physician-led and supported by specialists, so patients can receive the treatment they need right here at home. When every minute matters, dedicated caregivers are here for you. San Juan Regional Medical Center, serving the Four Corners region for generations. Find out more at sanjuanregional.com. Ready to make a difference close to home? The University of Denver Graduate School of Social Work Four Corners program is accepting applications for the 2026-2028 Master of Social Work cohort. Classes meet Fridays in Durango, letting you keep working. Learn more at du.edu/socialwork/Four Corners. Students can change the future with DU and apply now for lasting impact.
Now back to Studio A and the award-winning Scott Michlin Morning Program on KSJE.
And joining me in the studio this morning, as I mentioned, to talk about healthcare and AI, Dr. Carlo Hallak is here this morning. He is San Juan Regional Medical Center's Physician Informatics Executive. Dr. Hallak, good morning.
Good morning. Thank you for having me.
Thank you for being here. It's great to have you here and to talk about this interesting job that you have, which seems really fascinating. It's probably a job that hasn't been around for very long at most hospitals, I would think.
Yeah, so we are in what I call past the high-tech act phase. So now we are in a place where we need to make sure that the technology is supporting clinical decision support and supporting clinical operational outcome.
Right.
So back in the days, we were just putting in EHRs. Today, we're taking it to the next level. Well, basically bringing generative AI and AI tools to help with clinical decision support for the physicians and the care team in general.
Gotcha. EHR is, again, that electronic health record is what that stands for, sure. And then to go, as you mentioned, to the next level, and I guess it just makes sense because we're seeing AI in more and more of our daily lives. I shouldn't be surprised, I guess, that healthcare is also interested in learning how maybe it can help your staff to make their decisions, I guess, right?
Absolutely, yeah. So the most important part in healthcare, this is not a first come, first served type of business. It is really based on the patient condition. So all these tools that we're trying to implement for the physicians and the care team in general have to be tools that will allow for condition of the patient to be surfaced up. So if you're sicker, we need to present this data first. We need to make sure we'll put you up on the list so we take care of you first so you don't deteriorate your condition. So those are the things that are a little different than, say, an AI tool in a banking system or in different type of health industry.
Sure. But you've always done some type of triage, right, with patients as they show up. And so this is making that faster, or how does that help you?
So it is making it faster, and it's allowing the care team to practice at the top of their license. So we're surfacing information at the right time for the right caregiver at the right moment. And also it is patient-centric, so it allows for this important information because there's a lot of data in the record, but we want to surface up the important information for the caregiver at the moment of care so they pay attention to what's really important for that particular patient.
Interesting. And so you are introducing this to the staff at San Juan Regional Medical Center, this concept and this idea, I guess, yes?
That's correct. We're just at very early stages. So far, what we have implemented is a clinical AI agent that allows for node generation. So it's an ambient technology that will listen as the physician is having encounter with the patient. They'll be able to talk to the patient without being glued in front of a screen and creating that barrier between them and their patients. They'll be able to listen. The patient can have speak freely, and it will be able to understand plain English language into a clinical language as it translates it into the office note or the note in the hospital as well. And then the physicians could still review it at the end, make changes if they need to. It will be able to actually eliminate side conversations. Say, my grandkid has a soccer game on Sunday. That won't be added to the note, but it will be obviously part of the conversation. And that would eliminate that time for the physician to walk outside of the encounter and still sit there and type note. That note is already generated. They review it really quick, make quick changes, and then sign the note. That would save a lot of time. So it's a throughput impact. At the same time, it captures a lot of details that could be omitted back in the days that would also highlight the important pieces for the physician as well to pay attention to.
Got you. So something that maybe non-medical folks might be familiar with, like a voice-to-text type of technology that is then inputting that information from the conversation that the doctor's having with the patient onto that health note, that eventually that medical record, I suppose, and that would then be useful, I guess, for further treatment of that patient and whatever their concerns are.
Yes. So this is, again, early start. There's a lot more to come in the future on this. So the first is we're doing the ambient technology. It listens, but it is not just voice to text. It is also has a brain in it, so it can translate lay terms into clinical terms on a clinical note, and at the same time, it will allow for the physicians to actually review them and sign them. So they're still in control. So still there's a human in loop, like we say in AI terms, and it is really trained for health grade. So it is not just trained for general conversation. It's really trained for a healthcare context as well, the AI agent.
Got you. I oversimplified it, and I apologize. There's a lot more to it than as you explain it to me. That makes a lot more sense. And it sounds like then, too, there are some checks and balances, I guess, as well, and still some human interventions, if necessary, or human interactions with this new system.
Correct. Yeah, so the difference here is someone created a great innovation back in the days and called Scribe. So the scribe would walk in with the physician or the provider into the exam room, and the scribe would just basically be scribing as the provider and the physician talking to the patient. Now we have an AI agent that actually captures this information. So it's an assistant, but it is a little bit like a resident level type of information from a medical knowledge, and it allows for that AI agent doesn't get sick, it doesn't take a day off, it is constantly available all the time, and it keeps the physician in the driving seat. They still have to sign that note. They still can review the data. They can still edit the data
Right.
if at times the AI agent makes errors, which is very rare, but it does, obviously. And so that's basically, it doesn't eliminate the physician. It keeps them there. It actually helps with throughput and the delays in the conversations.
Sure. And as you were mentioning before, it sounds like it saves the provider some time because they're not having to be a part typist,
Correct.
part healthcare provider when dealing with patients. And we know that a lot of times these healthcare providers are dealing with numerous patients throughout the day, throughout the hour for that matter, right?
Yes, absolutely, yes. It actually helps us eliminate the time needed to do double documentation. So you're listening, you're taking some notes, then you're going back out, and then you have to chart and then sign the note and move on to the next patient. So hopefully it will help with this, seeing more patients.
Right.
And at the same time, the notes will be very well structured. It saves that time that they used to take before.
Sure. Or I guess too, that could be a crazy thought. Could the healthcare provider spend more time with a patient?
Absolutely.
If necessary, because they're
Absolutely.
saving time with this other
They'll be able to focus
task?
on the patient, more eye contact. There is no barriers between them and the patient, no computer in the middle. All they have to do, obviously, you take a consent from the patient that they are okay to use an ambient listening device in the meeting. But
Right.
as I said, this is just the beginning. The next phase to this is going to be queuing up orders. So as the physician is telling the patient, I need to prescribe some antibiotics for you, or we need to get you an x-ray. Those will be queued up as tasks, and the physician can see those queued up. Again, they don't have to type to find those. They'll be queued up for them. They review them, and they sign these orders as well. And there's a lot more coming with this technology that we're introducing.
Got you. This is just the very early stages, it sounds like to
Absolutely,
me.
at this
And
stage.
and so at San Juan Regional Medical Center, obviously the hospital has embraced this concept, this idea. That's why you're working here.
Absolutely.
And sharing all this information with your colleagues at the hospital. And so how has the reaction been so far? Because I would imagine it's pretty new to a lot of folks, and maybe even electronic health records aren't necessarily that old, although they've been around for a while.
Yes.
Anyway, what's the reaction been?
Yeah, so I've been in the informatics business and health IT business for a good 10 to 15 years. This is the first time in my career where the physicians and the care teams are coming to us and saying, we want this technology. They were always pushing back against technology in general. Look, I don't care. You give it to me. I have to use it. Yes, it helps a little bit, but for the longest time, the EHR, it was a good storage tool. It saves data in, but it was not really generating excitement. So this tool is bringing joy to practicing medicine. So we hear a lot of physicians are staying, extending their retirement dates.
They're staying on the job,
Staying on the
working,
job,
yeah.
working, because it feels that this is something they're asking for it. And we couldn't have done this if it wasn't supported by senior leadership and, from the board to the senior leadership, for someone like me to go and just implement a tool like this.
Right. And I guess that's really interesting. And I guess the thing is that they can maybe see the positives of this tool, as you mentioned, right?
Yes.
By adding it to their repertoire of skills.
Absolutely. Yep.
That's great. And the next step, I guess, then would be what do you
So
foresee?
the next
'Cause
step, so we are in the process of putting together a governance structure around AI technology, because we have to do it in a manner that is safe, that is equitable, that is not biased. Like I mentioned, AI tools there is a big hype. There's a lot of billions of dollars behind it, a lot of companies that are popping up. So we have to do it in a way that is safe, that is really based on evidence. And we're not just implementing tools because they look good. So it has to allow for risk stratification. It has to allow for ability to understand, explain how the outcome is coming out. So we need that explainability as well as we implement those tools. And we need the physicians and the care teams, the nurses, the providers to be part of those conversations as we're implementing those tools. So one of the other things that we're doing right now is implementing an AI-enabled chart summarization tool that will actually take the chart and summarizes the important information, will trend the data, and it will risk stratify the data. Again, I keep on stressing on this because the physician need what is important to them. And also something that we couldn't do before is that tool also, it's called well sheet. It allows for the tool to read unstructured data. So it can read a wrap PDF that is scanned into the record, and it can pull the important impressions from, say, the cardiologist in the cath lab or radiologist and surface it up to the primary care physician and then say, this is what we found there. And also it allows for this information to be surfaced up so physicians can take action based on the right information, again, at the right moment for the right caregiver.
Got you. And so, but we're not looking at maybe this AI model diagnosing a patient or offering any diagnostics yet, are we? Yes.
So at this point, it is we don't have enough evidence, and there are very few tools that actually allows for this to happen. And the minute there is maybe one tool that does diagnosing for eyes, and they had to do FDA approval for that tool, because now you're allowing a machine to make a diagnosis, and now it introduces that risk. So there is that fiduciary responsibility at this point because it's making decisions. So as long as the physician is making the clinical decisions and the tools are just assisting the physicians, then they're not diagnosing. The physician is still in the driving seat, and the nurses and the caregivers as well are in the driving seats.
They have the final say.
They have the final say.
For anything. It seems like, right?
Yes.
They can override or veto whatever
Absolutely.
the AI agent is saying. And I guess it seems like this is so new that maybe there's not a lot of government oversight, regulation yet, and that's why maybe the hospital is coming up with its own kind of guardrails to make sure this is used appropriately and as a tool that can really help its staff.
Absolutely, there is not a lot of regulations around it, and what we're trying to do from an informatics community is to go and put those guardrails, because what happened is when we didn't before, then we got a lot of regulations from the government, and now you have to comply or you get a penalty. So I think the healthcare community and the large academic centers are putting guardrails around the best way to implement AI, and to allow for, as I said, to eliminate bias and to make sure that it is evidence-based. So there's a lot of hype because there are trillion-dollar companies that are releasing those tools, but we need the physicians and the caregivers and the nurse practitioners to be part of those conversations. We need data scientists to come and do the research, and we need what's called the randomized controlled trials that actually will look to show that there is evidence that those tools are impacting clinical outcomes. And this is very rare in between today, that AI is making those changes. Still, the physicians and the caregivers and the nurses are the ones who are making impact on the outcomes for the patients, not the AI tools. They're just helping, but they're not the ones who are making those outcomes and impact.
Sure. And do you think that this is something maybe that the medical schools are going to start adapting to introduce the concept at least to their students, who are going to be then our future doctors and healthcare providers?
I hope so. I hope that they're trying to do this. I know that pretty much everywhere you go, there is an AI policy being put in place on how to use it. We need to do this for the medical students and the residents, because they're going to go to what is called a public large language model. And those public large language models, they make up stuff. It's also known as hallucinations. So we want them to be using tools that are health grade tools and, controlled for a health context,
right,
and not rely on, other large LLMs that can make up stuff. I can give you a quick example.
Please do.
I forced one of the LLMs to actually prove to me that beryllium, which is a drug that's been retired from treating heart conditions, that it is good for the heart, and show me evidence that it's good for the heart. Because the large LLMs and public ones want to please the questioner all the time, it managed to find a study that shows that beryllium is effective, when in reality, if you prescribe beryllium today, you lose your license. So the LLMs, the public ones, they try to please the questioner, and then you can force them to answer the question the way you want to. Health grade ones, they will actually refuse to answer the question the way you want it, because it's in a controlled environment. It's trained by physicians, by nurse practitioners, by physician assistants and providers, in order for it to be actually health grade. And that's where the difference would be.
An important difference.
It is a huge difference.
Right, right. And I guess, too, did these also, or could these models then maybe show their work, as you will, to kind of explain how they came to their conclusions and show the physician, show the person asking the question, this is what I'm saying and this is how I got to this conclusion?
Yes, so technically we call this explainability of the model, and this is going to become tougher and tougher the more the models become sophisticated, because we're getting to a point where they are really at a very high level, at an attending level, meaning a practicing physician for more than 10 years level, and they can do deep research and they have the ability to actually discern between different things. So it's becoming at a point where it cannot explain the outcome. We can see the outcome, but it cannot explain it. And that is a dangerous area. And that's why randomized controlled trials are extremely important as we implement and deploy these tools. They need to be there. So there is a couple of pieces here. One is the operational tools that would help with operations, save times on, patient-centric type of tools, registration, scheduling, follow-up visits, calling the patients to check them in, make sure they don't forget what they need to bring in, so you don't have same-day cancellations of surgeries and appointments and things like this. So these are like operational type of tools, extremely important for really a good operation of a hospital. With the challenges with really workforce, we need those tools to help us also around, virtual nursing or ambient technologies that allow for faster documentation and what I would call the repetitive actions that, today we have caregivers doing. Potentially we can automate those repetitive actions. So that's one layer of how we can, use AI in the future, and this is something we're looking into. The other layer is around clinical decision support. We need to rely on evidence-based published material, best practice published material in order to give those tools to the caregivers so they can leverage, again, evidence-based material. So that's why at St. Juan Regional Medical Center, we've invested with, Wolters Kluwer UpToDate, which is evidence-based, physician published material, and we are embedding those tools inside the EHR with our AI well sheet chart summarization tool. It's going to allow for that integration with clinical decision support that is based on evidence, and it will surface the data to the physicians and the caregivers and the providers so they can take action based on the patient's condition and the information in the chart. And those tools are not going outside to the internet to bring in, make up stuff. It's really focused on the patient at hand, and that will allow them to actually take those actions looking in front of them.
Got you. And so different levels, I guess, of this intelligence, if you will, right? And so it's fascinating, and I can see that it can be a really great tool and maybe offers a lot more possibilities as well. I mean, it wasn't too long ago that we have our first surgical robot now here in San Juan Regional and to San Juan County as well. And so all these things, I think, are progressing, right?
Absolutely.
And it kind of makes a lot of sense. For right now, though, I just want to make sure we explain to patients what they may be dealing with when they go to see their primary care physician or their healthcare provider, and that's really just this kind of acknowledging and accepting that they're going to be, their conversation is going to be recorded by this device, and it'll be put into this healthcare note.
Correct.
That's the first
step. We have
step.
a consent form, and they'll see it right when they walk in, and if the patient says, no, I don't want the technology, the physician will just continue having conversations with them without it.
Still the patient's choice. It's
still the patient's choice, always patient-centric.
Right. But I guess, again, this is kind of the direction that things are headed. And I guess, too, could you see a day when a patient maybe presents with some very complicated health challenges and a physician may be going to a tool to try to figure out what the best treatment is or what else it could be? Maybe the doctor has some theories of what the problems are, but this tool could also say, have you considered X, Y, or Z?
Yes, that's the promise that we're hoping for, because we are, as I said, we are embedding those clinical decision support tools, evidence-based clinical published journals from UpToDate and other tools as well. So those, if the physician wants to actually try to understand that complex condition, they'll be able to use what's called expert AI from UpToDate, and they'll be able to search, and that will basically aggregate all the clinical trials that actually address that condition. And since it's embedded inside the EHR, so it's actually looking in context of that particular patient. So it can see your vitals, your lab studies, your x-rays, your cath lab, your whatever other studies that were done for you. It will be able to look at all of this, and based on your condition, it will basically say, hey, we think this is the condition, and those are to support the material. These are the clinical pathways that we recommend you take, but still the physician is in the driving seat. They can look at those guidelines, they can read this information and take their decisions on how they want to move forward with the patient.
Got it. And I would think that maybe over time, this isn't all that different from maybe what physicians have been doing for forever, whether they're referencing medical journals or medical books or even the internet in some capacity, even today, right? This is not new, that a physician may reach out to other sources and resources to either confirm or help make a decision.
Yes, we're just trying to expedite, and we're trying to surface it up to them in context of the patient before they have to go and open and read outside of context. Now we're actually putting the patient in context of that condition, and they're getting information related to those values that the patient has and those parameters that the patient has. So it's going to expedite that work and that research for them as well.
Got you. Very exciting, and
very exciting.
Very interesting to hear you describe it and to hear about how it can be used. And I think it certainly opens the door to a lot of fascinating possibilities when it comes to modern medical care and treating some of these really chronic conditions that folks have and offering relief from.
Yes, the future is very promising. Again, we're hoping and pushing for more randomized controlled trials. There's another concept called pragmatic RCTs, and those, when you have a tool, you implement it in a basically environment where it is a test environment. So because we're implementing it in hospitals and in the real, where the things are happening, not in a lab. It's not just, a study in a theory, but it's happening in real time. Then we can gather the information and then infer from it and then tweak the model to allow for better outcomes. And again, the most important thing is explainability. Can I explain to the physician who's using that tool how the tool got to that outcome? And then this way they'll feel that they can trust it and that they can actually work with that tool because it's explaining how it got to that result.
Right.
It's nothing different than how at school, when we're doing basic prove your work, it's very simple principles. It's the same simple principle. Prove your work. How did you get to that result? And this way I can trust it, I can work with it, because then it's not random. It is really based on a good algorithm or a good model, AI model.
Right, which is very important.
Yeah.
And again, I guess when the patient asks the physician, how did you come to that conclusion? The physician can prove their work too.
Yes.
And so that's very important. So great.
Yes.
Well, fascinating conversation this morning with you, Dr. Hallak. Thank you for coming in this morning. Thank you for the work that you're doing at the hospital. I hope you'll come back and give us an update.
Absolutely. Thank you so much for your time.
You're very welcome. Nice to talk to you. That's Dr. Carlo Hallak. He is with San Juan Regional Medical Center, my guest this morning here on KSJE. Did you enjoy that podcast? We hope that you did. And if you did, share it with your friends. And if you really want to keep podcasts like this coming, please support KSJE. You can do it easily online at ksje.com.